Now move on to our next talk of the session on when laboratory investigations are not required. This is by Dr. Padmamalini Mahendra. Of course, you all know her. She is the Vice President of Uveitis Society of India and is currently heading the uveitis services at Narayana Nethralaya, Bangalore. And she's going to cover one of the most important topics again for the general ophthalmologists who see uvea patients, where we all tend to order a battery of tests when actually it may not be required. Dr. Padma.
Thank you, Dr. Reema, for the kind introduction and invitation. Very good evening to all of you. The topic was given to me was, do we always need to investigate? Whenever a patient presents to us, we need to tailor make the investigations and try to find out the cause. The standard approach to uveitis is a stepwise. We'll take good history taking, examination, investigations, and management. Now, we have to avoid investigations. Without that, how are you going to manage? In which cases can we skip the investigations? Here is a case of a lens-induced uveitis. When you know the lens is the culprit and inflammation is secondary to that, we address the cause in addition to appropriate anti-inflammatory therapy where you don't have to investigate. What I mean is laboratory investigations are not required. Second is a traumatic uveitis. It's a blunt trauma which resulted in uveitis. You treat these patients with anti-inflammatory therapy and closely follow up for the development of secondary complications. Or in a case of a penetrating trauma which is self-healed, no evidence of infection. Once the inflammation, they respond well to anti-inflammatory therapy. The fourth entity is whenever we have granulomatous panuveitis, conditions like sympathetic ophthalmia, you know that there is an history of injury involving the ciliary body that is exciting high, following which the patient develops panuveitis, inflammation of the anterior and posterior segment of the sympathizing eye, you are dealing with a case of sympathetic ophthalmia. We don't need investigations to make the diagnosis. However, we order investigation to start the patient on treatment and monitor the response to treatment with systemic steroids and systemic immunosuppressive therapy. The next is a case of a VKH where we have bilateral exudative detachment. We make the diagnosis based on the clinical presentation. These extraocular manifestations like alopecia, poliosis, vitiligo, tinnitus are all developed later in the part of the disease. The next entity is Fuchs uveitic syndrome. Most often, it is underdiagnosed and overtreated with corticosteroid therapy. In the textbooks, wise Fuchs does not need investigations, but we do ACTAP for PCR for viral genome if you are suspecting a conditions like CMV anterior uveitis or other viral uveitic entities. So to summarize, whenever we see a patient with case of a lens-induced uveitis, Fuchs, traumatic uveitis, the literature says first episode of acute non-granulomatous anterior uveitis we don't investigate, but I like to do a thorough systemic evaluation. If I find any history of low backache or other systemic findings, I like to investigate even in the presence of first episode. We need to tailor make the investigations based upon the clinical presentation. The VKH and sympathetic, these are the entities where we don't order laboratory investigations to make the diagnosis. Since it's a case-based, now we'll move on to the cases. 78-year-old man presented with redness and pain watering in the right eye since 2 days. On examination, circumciliary congestion, 2+ cells and flare, fundus examination was normal. We would like to start the patient on topical steroids and cycloplegic agents and try to find out what could be the reason. But on systemic evaluation, the patient had viral wart in the periocular region. On probing the history, patient used topical phodophylline, following which he developed redness in the eye. So this is adverse drug reaction. Probability scale of 7 was obtained, suggesting that anterior uveitis in this case was probably secondary to the use of topical podophyllin. Topical podophyllin was stopped and topical steroids and cycloplegic were continued, which resulted in resolution of the inflammation in this case. Next, move on to the case 2. It's a 37-year-old lady presented with complaints of redness and discomfort in both eyes, defective vision on and off for 9 months, and she gives history of flu-like illness. She is also known asthmatic, and for eye inflammation she has been using topical prednisolone, timolol, and she used for oral moxifloxacin for the systemic flu-like illness. On anterior segment, you could see fixed mid-dilated pupil, deep anterior chamber with patchy depigmentation of the iris. There was a flare, occasional pigmented cells. Pigments over the endothelium were seen, and this is not the cells, active cells. These are pigmented cells floating in the anterior chamber of the eye and also the anterior segment of the lens. You could see few depigmented patches on the iris. The gonioscopy revealed open angle with pigmentation of the trabecular meshwork, where we could see the heavy pigmentation of the trabecular meshwork in both eyes. Fundus was absolutely fine. What could be the diagnosis? We made the diagnosis of bilateral acute depigmentation of the iris, what we call it as BARDI, following systemic moxifloxacin use for the flu-like illness. Here, topical steroids were stopped. Anti-glaucoma medication was continued for some time. This is a progressive, and after some time this stabilizes and the repigmentation of the iris appears. So, conditions like BARDI, we do not treat them with topical steroids. You just observe with close monitoring of the intraocular pressure. This is a drug-induced uveitis due to various agents like PG analogus contraindicated in uveitis, and quinolones, especially the systemic ones, can cause body-like syndrome. Recently, we have among the vaccines, COVID also have been listed up. Next case is a 52-year-old male presented with recurrent postoperative uveitis. Here is the patient is taking recurrent uveitis for the past 4 months. Whenever you use the topical steroids, inflammation comes down, and after stopping it comes back. There is no systemic history, is absolutely fine. Posterior segment is absolutely normal. On close slit lamp biomicroscopic examination, we could see the presence of cotton thread in the side port. That is the reason. So, as long as the patient is using the steroids, inflammation is under control. The minute they stop, it comes back. Here, cotton thread was removed. Subsequently, there was complete resolution of the inflammation. So, these conditions like this, we don't investigate. Case 4 is a 16-year-old boy presented with redness and pain, watering and blurring of vision since 2 months. He had circumciliary congestions, fibrinous anterior uveitis, already had a posterior synechia. Fundus showed hyperemia of the disc with media haze. Here again, during the COVID time, when we probed the history, clinically we made the diagnosis of panuveitis. When we did the fundus when we did the systemic examination, we saw the inflammation of the gum, what we call it as a gingivitis. The patient was put on systemic antimicrobial and anti-inflammatory therapy with topical steroids, which resulted in resolution of the inflammation. So, if the eye cannot see, what the mind does not know. To summarize, we saw 3+1 4 cases where the investigations were not necessary. Gingivitis, podophyllin-induced toxic uveitis, and bilateral acute depigmentation of the iris, and post-cataract presence of cotton fibers. So, this highlighting the importance of thorough clinical examination to finding out the cause of uveitis, in which case we do not have to investigate this patient unnecessarily. I'd like to acknowledge her team. Thank you for your attention.